excited to be having this webinar. Um, let's see, my name is Dr. Linnea Welton. I'm a board certified orthopedic surgeon, and I'm head of the hip preservation service for MultiCare Health System. And I'm establishing the premier health preservation program for the Pacific Northwest. So I am both fellowship trained in hip preservation surgery, but I'm also fellowship trained in sports surgery and sports medicine. So I do management and surgical procedures around the hip, but I also have a very active sports practice. So I see a lot of athletes and I help take care of a lot of ACL tears, meniscus tears, cartilage defects, patellar instability, stuff like that around the knee as well. Finally, I also run a small biologic injectable practice, and we'll talk briefly about that down the road as well. So let's move. I'm trying to, I don't know why my screen's not, oh, there we go, we'll just go that way. So again, you know, background, I'm from the Pacific Northwest originally, went to University of Washington, and then traveled throughout the US for my training from University of Michigan to University of Colorado, and just, you know, Pacific Northwest is home. So glad to be building this program here. When I think about a hip preservation service, you know, it's really not just about me and what I can bring to a patient. I kind of think of the service as a trifecta. When you have myself, the orthopedic surgeon, but I also have an athletic trainer. Her name is Lisa Kenny, and she is integral in providing seamless care and high quality care to our patients. She's a certified athletic trainer and has years of both on and off the field experience. And then also our PAs, Krista Guile, for example, I have trained her in both hip preservation and in sports medicine. And so she plays a very integral role as well, both in helping me to initially see, evaluate, and manage some patients depending upon where they are at on a treatment algorithm. She's also very important in assisting me in the operating room. And then the PAs are helpful in helping us make sure that patients are recovering well after a surgical procedure and going through the rehab process as smoothly as possible. So I always think of patient care as kind of a triangle where it's myself, our athletic trainer, patient liaison, our PAs, and then the patient is in the center of this care triangle. So my objectives for this talk are several. One is I want to just give you a basic rundown of the anatomy of the hip, why I think it's such an interesting you know, joint to be focused around. I will talk a little bit about what hip preservation is, what are some of the common diagnoses that I treat, how do I treat and manage those. We'll talk briefly about biologics, and then of course next steps. So basic hip anatomy. I like to think about the hip from the outside in. You know, the hip joint is really one of the deepest joints in the human body. And so beneath the skin, we have this very thick and strong soft tissue envelope made up of many muscles and tendons. There's ligaments and capsular tissue. There's the labrum, which is part of the hip joint, and we'll talk quite a bit about the cartilage in the joint, the bones around the joint, and then the nerves and vessels, and then both spine and pelvic organs as well that we all need to take, that I need to take into consideration when I'm helping to evaluate somebody. So some of the most common muscles that I'm always evaluating when I'm seeing a patient for the first time, one, to see if they're not the primary pain generator versus if there may be a compensatory component to what their pain is being driven by. Some of these muscles are the hip flexors, such as the iliopsoas and the rectus femoris. The tensor fascia lata and IT band, as well as the glutes, are kind of the muscles on the outside of the hip, and they're really important in allowing a patient to walk, to balance, to go from seated to standing. In the posterior and sort of the buttock region, the hamstrings are also a really important and potential part of somebody's pain, especially for athletes. And then the adductors, which are a muscle group that help to bring the the hips together, the knees together, very important in walking and running. And they are often inflamed when the hip joint is also aggravated by injury. So beneath all of these muscles, we have the ligaments, and these ligaments are some of the strongest in the human body. And along with the ligaments are the capsule, which is what makes the hip a joint. And then within the joint is the labrum, which is a cartilaginous ring around the socket. Beneath that cartilaginous ring, there's the cartilage, and the cartilage of the joint is made up of both the socket, which is called the acetabulum, and the femoral head, which is the ball of the joint. And these make a very sort of concentric, usually very stable joint. Just below the femoral head, you have the femoral neck. And then below that, you have the trochanteric region. And the trochanters are these protuberances that are where some of the muscles around the hip attach to. So in addition to the muscles and the tendons and everything else, there's the nerves and the vessels. So the nerves certainly can be a cause for pain. And whenever I think of the nerves, I always think about the back, because the lumbosacral spine is very closely associated with the hip joint. And so they can sometimes, the spine or the hip can mimic each other, but they can also cause multifactorial pain, such that it's not uncommon that I see patients that have hip pain, but they also have some sacroiliac pain, just because they've been compensating for a period of time. So now, what is hip preservation? So to me, in the most sort of simple and clear terms, it is the diagnosis and treatment of non-arthritic and pre-arthritic hip conditions. And my goals for patients when they come in to see me are, one, of course, to improve their pain and symptoms, to increase their motion and stability if they're having these types of symptoms, allow unrestricted return to activities. And then we have this potential, depending upon the patient and upon the condition, to potentially preserve the native hip joint and prevent the need for future joint replacement down the road if they don't have any arthritic findings at the time that they see me. So how do I go about doing this? On a day-to-day basis, when a patient comes in to see my team, whether it's myself or it's one of our PAs, we do a really detailed history. I want to know, not only where the patient is having pain, but what do they do for work? What's their activity profile? What are the activities, the things they like to do and want to get back to doing? What are their other medical problems that could be playing into their hip pain? We do a really thorough exam, looking at not only the hip, but the entire lower extremity as well as the back. I also get some really specific x-rays to help me evaluate and make certain measurements around the hip joint. Sometimes we use some injections to help diagnose conditions. And then in many, many situations, for patients that have not done any physical therapy, that's oftentimes the first thing that we really want to make sure we have tried before we start thinking anything, terribly invasive. Anti-inflammatories and injections are also really critical. And then, of course, I'm an orthopedic surgeon, so I love operating. And so I do a lot of minimally invasive arthroscopic surgery as well as some open procedures as well. So before a patient comes in to see the hip preservation team, what are often times things that we would like or patients have had done? Well, first, getting a standard hip x-ray, whether it's with their primary care physician or another orthopedic group, to show us whether or not a patient has, advanced arthritis or not. If a patient has some pretty significant and advanced arthritic change, I probably am not the ideal person for them to see. But in those patients that are not at that stage in their hip process, then having them try some physical therapy, usually for about 6 to 8 weeks, and try some anti-inflammatories like Aleve or ibuprofen, and potentially getting an injection into the injured or damaged area to help kind of hone in on where that pain is coming from. are things that we often see or often want to have had done before they come in to see me. Now, caveats to this are there are some, critical diagnoses such as osteonecrosis or avascular necrosis of the hip, or a high-grade hamstring tear that's just occurred, where, if an MRI shows that and get that in a report, then, I want you to contact myself or any hip preservation service so that you can get treated and seen, right away. So some of the common diagnoses that I see and that we'll talk about today are hip labral tears, hip impingement, that's also called femoroacetabular impingement, or FAI for short, hip dysplasia, gluteus medius tears, proximal hamstring tears, snapping hip, piriformis syndrome, things like this. Now, what is the hip labrum? All right, I see a lot of patients that come in with MRIs showing a report saying that they have a labral tear. So the labrum is a cartilaginous ring that goes around the hip socket, that lines it, and it kind of acts as a gasket. It helps to lubricate the joint. It helps to provide shock absorption and sort of stabilize that structure. Now, the really important and I think interesting thing is that studies have shown that if we look at a large group of adults in the United States or anywhere in the world, and we get an MRI of their hip, just to get the MRI of the hip, about 40% of adults without hip pain or hip symptoms actually have a labral tear on an MRI. So not all labral tears are painful. And that means a couple of really important things to me. One, it helps me know that if you can have a patient or a person walking around without pain and they have a labral tear, it means we have an opportunity non-surgically to potentially make them non-painful. So usually, again, that's one of the reasons why we really try physical therapy and anti-inflammatories, sometimes injections, to see if we can get that patient back to baseline without surgery. And of course, if they fail that, or not able to get back to what they need and they want to do, then we can oftentimes do hip preserving surgery like hip arthroscopy to repair that labrum. Now, the other thing about the labrum is that a labral tear sometimes is not a diagnosis in and of itself. Sometimes a labral tear is part of a constellation of findings that we see in something called hip arthritis. Excuse me, and arthritis is when we start to see basically degeneration in the joint. Usually that means that we get cartilage thinning, cartilage loss, hardening of the bone around the joint, and the labrum can tear with this degenerative process also. And when we see this labral tear with hip degeneration, then it's part of what we call osteoarthritis or arthritis, and it's not necessarily treated any differently than hip arthritis. So who are our labral tear patients that we treat most commonly in this field? So they tend to be very active, young to mid-age adults. I would say the vast majority of cases that we treat are patients between the ages of 25 and 45. But there's certainly, if you look at the bell curve, we certainly see patients starting at around 15 and up to the age of 55, but sometimes it really depends upon their physiologic age. Pain in the front of the hip or in the groin is oftentimes a presenting symptom. Pain with sitting, running, standing activity, all can be a presenting sort of modality of pain. And some folks will actually have a mechanical kind of catching or clicking when they're moving their hip, and that's part of their symptomatology as well. Now, one of the reasons for why we develop a labral tear is due to something called hip impingement, all right? And cam-type hip impingement tends to be one of the most common types of impingement that I see. And what that is when you look at the femoral head, as it transitions down to the femoral neck, there's this extra bump of bone. And so what that does, and I'll use my hands, I hope you can see it. If this is the socket of the hip, my hand here, and my fist here is your femoral head, and let's say my wrist is your femoral neck. If you have a nice narrow neck as you go through a range of motion, it's going to take a really large range of motion for the to impinge. Now, if you have a flatter neck, it's a narrow range of motion before the two conflict. Now, what gets pinched upon or impinged upon is the labrum, which is that gasket that goes around the joint. And so this is a type of, or a method or a pathology for why we get labral tears. Now, on the other side of things, instead of just the femoral head, the socket can also be a cause for impingement. So if the socket is either too deep or if it has just an area that has a little too much bone, you can get a similar mechanism of that labrum getting pinched and then torn. And of course, there's a mixed type of impingement where you see both the socket and the femur side that can cause that labral tearing. So again, when we see a patient that has hip impingement and we suspect they have a labral tear, we know they have a labral tear, what are some of the things that we do initially? Well, first, we try and kind of reduce the activities that are really aggravating the patient's hip. We try physical therapy. And what we find is that a lot of patients, when they've been compensating for this labral-related pain, they tend to compensate in a couple of different ways. Usually the hip flexors will get, the muscles in the front of the joint will get a little aggravated and they'll get really tight. And then as they get tight, then the glutes, our posterior or our booty muscles, they tend to start to get weak or they get a little neglected. And so we try and kind of reconstruct normal mechanics and get our strength back to see if we can compensate in a more healthful fashion. Along with that physical therapy, we try anti-inflammatories, whether it's over the counter, Aleve or ibuprofen, or if it's something I can prescribe like Celebrex or diclofenac. And then injections, both corticosteroid versus biologic injections. And sometimes we also do an injection of just a numbing medicine to make sure that we're really hitting the nail on the head. And so that's when what brings me kind of to the workup, because not only do we take this history and we do this exam, but I also use imaging. So I get a very specific set of x-rays that allows me to do about 15 to 20 measurements around the hip to make sure that I'm understanding exactly what the sort of the bony hip shape or the bony cause for why a patient's having hip pain could be. And then we oftentimes will use injections, like I said, sometimes with just numbing medicine to make that hip joint numb so that we can confirm, is the pain coming from the joint or is it coming from somewhere else? Is it coming from one of those muscles that's surrounding the hip? We also use MRI or MR arthrograms to really get us a solid understanding of the cartilage and the labral surface. And that's where we get a lot of information about the muscles if we're concerned about a tear. And then before I do surgery on any patient for a hip arthroscopy procedure, I always get a CT scan. And part of what we see with the CT scan is I get a 3D rendering or a virtual 3D model made so that I can really precisely understand and plan that surgery, since the joint is a 360-degree structure. All right, so hip arthroscopy. What is hip arthroscopy? So it is a minimally invasive surgery. It's where I make usually 2 to 3 incisions around the hip joint, and they're about the diameter of my finger is all those incisions. And that allows me access into the joint with a small camera and then with small instruments so that I can go and I can repair the labral tissue. This is just a demonstration or some of the pictures that we can take during surgery of how I go and can repair a patient's labral tear. Similarly, and I think this is really can be quite interesting, this is a sort of a video demonstration of in surgery what we do to repair a labral tear. There's the tear, and these are some of the small sort of drill guides that I use to place a drill into and above the bone from the joint, and then I place a biocomposite anchor that's made specifically for the human body, and then I can pass sutures around that labrum that's torn, and then I tie that suture down so that now the labrum is reattached to the rim or to the socket of the bone. And then that allows it to heal back in place. And those sutures and that anchor, those stay in there for the rest of the patient's life. And we get very excellent results in the vast majority of cases. All right, so moving on to the next. I don't want to do that. So in addition to repairing the labrum, the other really important thing with a hip preserving surgery is that we also correct the bony hip shape that is causing or putting patients at risk for this to occur. So that cam type hip shape, I have to go and I have to correct that hip shape. And that's where I use the CT scan to look at where that bony bump is, and in 360 degrees. And then I use X-ray during surgery to help me sort of localize the whole view of where I need to correct that bony shape. And I use a very small high-speed burr to basically sculpt the femoral head and neck, so no longer do they impinge. And here's just a post X-ray sort of demonstration of what a cam type, what we call resection or recontouring, looks like after the surgery. Similarly, we do the same thing for a pincer type lesion too in certain situations, and the before and the after. And then in terms of the hip arthroscopy itself, so this is still a very new field when we look at sort of medicine in general and orthopedic surgery. Hip preservation and hip arthroscopy really came into existence in the United States really in the early 2000s, and when it started gaining a lot of ground. And how we used to traditionally get into the hip joint, because we have to make space, right, to get into this tight joint, was to actually pull traction on the patient's legs over a post that was placed in their groin. Now that post was very well padded, but it did come with the risk of skin tears around the scrotum or the vagina. Sometimes patients would come in for sexual dysfunction after this procedure, which is just these are complications we don't want to have. And so a bed was developed, and I actually trained on the prototype and helped to publish and was one of the some of the leading authorship in our validation studies for this bed, where we actually don't have to use a post. And I was the first surgeon to bring this to Washington State. It's called postless hip arthroscopy. And really over the past 5 years, this technique of doing hip arthroscopy has become the gold standard in the United States and is used widely now internationally. So again, just really exciting to be kind of in this field and helping to move things forward. So not all labral tears are due to impingement, all right? We should also talk a little bit about something called hip instability or hip dysplasia. And that's when the socket, all right, of the hip is not deep enough, or it's not completely round enough. And so you end up with a shallow hip socket, and that shallow socket can cause more of a shearing type damage to the labrum, because you're getting subtle shifts in motion because the socket is just not allowing that joint to be stable. And so this is really where, some of the x-rays that I get are important for me to take measurements to make sure that I'm understanding, how that hip is behaving in space as we're moving and why it could be causing that labral tear. And so in patients that have hip dysplasia, all right, and hip dysplasia is a very broad term. There's mild dysplasia, and there's frank dysplasia, and then there's this borderline sort of gray zone. And so some borderline or sort of mildly dysplastic patients, we really can, potentially take care of in a minimally invasive way through hip arthroscopy. But there's also a subset of patients with hip dysplasia where we have to do a more invasive surgery called a periacetabular osteotomy to basically cut the bone around the socket, free it up from the rest of the pelvic cavity, and then reorient it and then fix it with screws so that now that socket will contain the femoral head. Now, this can be a very successful surgery, and patients can get back to full activity. but it does come with more risk and certainly more involved, but also a very, a very good surgery to have in our wheelhouse now to be able to do for patients that come in with hip dysplasia. So not all hip pain comes from the labrum. And we kind of talked a little bit about this. What about patients where the labrum is also part of what we call arthritis, when we start to see hip degeneration, all right? That's when, if we can see patients in sort of a more mild form of arthritis, and this goes not only for the hip, but also in the knee, then we have an opportunity to use what are called biologic injectables. And these sorts of injections we'll talk just briefly about. One is bone marrow aspirate concentrate, what's kind of commonly known as stem cells. The other biologic is called PRP, or platelet-rich plasma, and it's PRP that I do a fair amount of in my clinic. And the reason being is PRP, or platelet-rich plasma, it takes out, from your own blood, all right, the platelets. We centrifuge your blood sample down and we take out those platelets, and they serve two main roles in the human body. One is platelets are part of the body's natural anti-inflammatory, anti-pain response. So we get a natural induction of reduced pain. And then platelets also are integral in the body's healing pathway. So when we inject platelets either into a degenerative hip or knee, or into a tendon that we're trying to stimulate some healing in, we get shuttling of thousands of growth factors. All right. And now those growth factors don't necessarily, they don't cause the cartilage to regrow, but they do provide a healthier environment for, the cartilage and the labral tissue that's there. And I think that's a good segue for me to kind of come back to stem cell therapy, in that, stem cells, or bone marrow aspirate concentrate, is very similar to PRP. I think when we look at the composition of the bone marrow aspirate concentrate, we don't end up getting a super high concentration of stem cells. And so what the product looks like is a little bit more like PRP than anything else. And on that note, the stem cells, the mesenchymal stem cells that we get, we don't yet know how to inject them into something and then tell them, hey, stem cell, turn on and turn into a cartilage cell, or turn on and now grow some new labral tissue. And so, again, that the stem cell therapy, I think, when we have figured out from a research standpoint how to do that, how to turn on that sort of regenerative potential and actually put it into a patient, it's going to revolutionize musculoskeletal care. But right now, stem cell therapy as I know it, as I feel is not yet there. And so I don't do stem cell therapy. When I think it's ready, then I will. But right now I do a fair number of platelet-rich plasma, PRP injections. And then for the knee, we also can use hyaluronic acid. And hyaluronic acid is a building block to cartilage. It's also called viscosupplementation. And that is kind of a lubricant. And so when you put this sort of cartilaginous building block into the knee joint, it sort of acts as, like I said, an oil change. It sort of fills in the nooks and crannies and can provide, I think, a smoother kind of gliding surface. But these are the biologic injectables that we kind of have on hand today. And so, like I said, the main uses for these are for early hip or knee osteoarthritis, for tendon tears or chronic tendon inflammation. And again, these are not disease altering. I would say they are disease, they're disease modifying in the sense that they modify the symptoms, but they don't actually, change the course of the disease. We talked about how bone marrow aspirate stem cells are similar in content to PRP. I think a really important thing also to understand is that bone marrow aspirate concentrate and PRP are not generally covered by insurance. So it tends to be an out-of-pocket expense. And my team, our departments tried to kind of work to develop the economics to make it as reasonable as possible for patients, but it usually is an out-of-pocket expense. Visco supplementation, so HA, has traditionally been pretty well covered by insurance, but I think we're seeing for whatever reason that sometimes it's not being as covered quite as much from insurance as we'd like. So that's just a brief overview of injectables, biologics. So what about pain that's outside of the hip? What about if we exit outside of the joint? What are some of the two big things that I see a fair amount of? Well, one is pain that's on the outside of my hip. And this is something that we call greater trochanteric pain syndrome. And greater trochanteric pain syndrome is basically, it can be coming from a number of different structures around the outside of the hip joint, namely the trochanteric bursa, the gluteus medius, the minimus, the iliotibial band, and sometimes it's a combination of all of these things. I would say most commonly what we see is bursitis with some chronic tendon inflammation. Even some partial tendon tears are really kind of sort of degenerative injuries. We commonly see these in females more than males, usually in their 50s and 60s. And now, even with partial tendon tears, as if you were to see them on the MRI, most of the time, the vast majority of the time, this does not need surgical treatment. But usually it does take a long time of some really concentrated physical therapy for 6 months, sometimes with a couple of corticosteroid injections. PRP injections can be employed as well. And then anti-inflammatories, if we find that they're helpful. In those patients where we really tried hard to get patients through this in a non-surgical fashion, we'll sometimes do surgery to try and kind of repair or restore these tendons, especially if they're having weakness on exam. The other thing, though, is if a patient has a high-grade tear, so significant tendon tearing with retraction, and there's weakness on exam or they can't walk normally, then that absolutely is an indication for us to go in and to repair that tendon back down to the bone. And on a similar note, if a patient, a younger patient or any patient really, like, I don't know, gets in a car crash or, has a sports-related injury and they're found to have this tear, then and it's a higher grade one, then we try and jump on that sooner rather than later to try and get that early healing restored as functionally as possible. What about hamstring injuries? So interestingly, hamstring injuries are the most common injury among recreational and elite athletes. And the reason is, the method of it is oftentimes, a patient is, or an athlete is trying to contract the hamstring muscle at the same time that the muscle itself is kind of being lengthened. And that's called an eccentric contraction. And that puts a lot of force across the hamstring itself. We see it a lot in soccer and football athletes, often in sort of younger but older, younger adults. The most common type of injury, though, is a strain. So very low grade sort of tearing of the muscle fibers itself, not necessarily a rupture of the tendon. And of course, the highest risk of having a hamstring injury is having had one before. So how do we treat this? All right, so similar to our greater trochanteric pain syndrome, we tend to do a lot of physical therapy, a lot of rehab, anti-inflammatories. We try PRP injections. I don't tend to be a huge fan of corticosteroid injections around this particular tendon. And again, the vast majority of injuries are in the muscle belly itself. And then, of course, when we see tendon tears, they tend to occur up at the top portion of the tendon as it attaches to what we call the ischial tuberosity, or what I call the sit bone. You can kind of feel that bony area that you sit on. That's where hamstring attaches. And so when we need to repair, we need to operate on this type of tendon or muscular injury is if it's a high grade tear. So if 2 of the 3 tendons are torn and they're retracted, or if all three tendons are torn and ruptured off of that tuberosity, or, and again, this is very rare, but if somebody's had a lot of long-term pain around the top portion of the hamstring, and they have tried non-surgical modalities for months and months and months and just not getting to where they need to be, then we'll sometimes go in and kind of repair that as well. So that concludes sort of the bulk of this talk. You know, my goal in life, all right, and professionally, is to really be the premier hip preservation and sports service in the Pacific Northwest. I love what I do. I have a great team. It's really such a passion, and it's so rewarding to get to work with patients and get them back to doing the things, the activities that they love. So with that, I will just kind of say again, you know, my scope of practice is hip preservation, but we also run a biologics clinic, and we have a very active, thriving sports practice, especially around the knee. And with that, I will say, if you want to come and see me, I will very much look forward to seeing you. The best way to make an appointment is to call my clinic at this number. There are websites, have a lot of information, and the website LinneaWeltonMD.com is something that I put together, and I really want it to be more of an educational resource for patients or the population, to answer questions, and of course it's a way that you can contact me as well. So with that, I will leave things open for questions. Thank you so much for coming and your time.
Looks like there's some questions coming through in the chat.
All right. What about pain in the piriformis syndrome? So piriformis syndrome is a diagnosis of exclusion. It is a very rare diagnosis. Oftentimes, you know, pain that's in the posterior, so it's a deep gluteal space syndrome, which is kind of like greater trochanteric pain syndrome, in that there's a lot of different things going on in the deep buttock that could be causing that pain. But we always want to look for, you know, most of the time, the sciatic nerve is irritated from impingement or narrowing or degeneration in the lumbosacral spine. And you can get referred pain down into the deep, sort of that deep buttock area. Similarly, I have a subset of patients, especially women, that will say, you know, doc, I've got such a deep pain in my buttock, and it'll turn out that it's actually coming from their hip joint, not necessarily from their glutes or from their back or from piriformis. But if a patient has piriformis syndrome, the best way to sort of confirm that, if everything else looks like it's negative, is to do what's called a piriformis injection. And that's where we put some corticosteroid and some anesthetic around the piriformis and the sciatic nerve, as that sciatic nerve exits usually below the piriformis muscle. And if that provides pain relief, then it kind of confirms that, yes, that's what's going on. Similarly, it's not only diagnostic, but it can be therapeutic. And usually we do, you know, a focused type of physical therapy called, you know, for piriformis syndrome, in conjunction with an injection, to really get patients over this. You know, in some instances, then yes, we do have to do a minimally invasive surgery to go and kind of release the piriformis muscle, or to sometimes there are vessels around the area that we have to cauterize, that can be kind of pulsating, you know, around that sciatic nerve. All right. Let's see here. What else? Where is MultiCare? MultiCare. So MultiCare is predominantly in the South Sound region. We have my practice is, I split my practice both in Covington and Auburn. but I am credentialed, and sometimes we'll do surgery down at Good Samaritan in Puyallup, Tacoma General, Allen Moore, Mary Bridge Children's Hospital. So those are all the sort of the clinic and hospitals on the west side of the mountains. But we also have, I think there's MultiCare in Spokane and Yakima as well. Let's see, notice to age 50. What about those way older? So way older. So again, if it's hip, like true hip pain, you know, that's coming from the labrum or the cartilage, hip arthroscopy in patients, beyond the age of 60 oftentimes have pretty reduced outcomes. There's a very high percentage, 30 to 50% of patients that end up going on to have a hip replacement, within 2 years of a hip arthroscopy. So we generally don't do those unless, there are some 60-year-olds, right, that can come into my clinic, or that, their physiology, they look more like a 40-year-old, and their hip looks, has no cartilage degeneration, no cartilage damage. And they're, very active, they're still skiers or golfers or runners. And in those, situations, then absolutely, there are exceptions to every rule, right? But generally speaking, the research has shown that we don't get good outcomes in patients, much beyond the age of, starts kind of 50, 60, and so on. What this next question is, I have had a PRP injection in my hip about 5 years ago, but I'm back to having hip pain. Does this rule out PRP therapy as a future option for me? No, absolutely not. So this is what I tell my patients, that, we oftentimes do kind of a loading dose of PRP. So we usually do 2 to 3 injections within a 3 to 6 week period of time into the hip or the knee, to try and get as much, kind of those positive kind of anti-inflammatory responders and those growth factors into the joint. And then we hope that that injection actually lasts about a year. So the fact that somebody's had 5 years of great outcome is wonderful. But if that injection, that series that I just talked about, lasts for about a year and patients start to have some recurrence of symptoms, then I say, well, let's have you come back in and get a booster. So, a booster, so to speak. So by all means, if you've had great success with one but your hip pain is coming back, you should see if you're a good candidate to have another PRP injection. Anybody else? Or I hope also, did I answer those questions? If anybody has follow-ups to those, please shoot. Okay. Well, oh, tell me about the psoas. Do you work on these too? Okay, here we go. Do you work on these too? The answer is yes, I absolutely do. So I see quite a lot of knee patients, mostly sort of sports related knee injuries. So ACL ruptures, meniscus tears, cartilage defects, patellar instability, multi-ligamentous knee injuries. Those are sort of the vast majority of the knee patients that I see. But then, I also do get referrals for patients that have some mild knee arthritis and are, really interested in biologic injectables. I see those patients too. The psoas. Psoas muscle. So the iliopsoas muscle is made up of the iliacus and the psoas, and those muscles originate sort of on the back portion of the iliac crest, as well as sort of the transverse processes of the lumbar spine, and then they flow kind of beneath your pelvic cavity, and then they come up and they roll over your pelvic brim and they attach onto the lesser trochanter. And so they are involved in hip flexion. And they are very much can be part of a patient's hip pain. One, because we do tend to see a lot of tightness or aggravation as as patients are trying to offload a hip joint, but they can also be a pain generator all in and of themselves. Some patients will get what's called internal snapping hip, where the iliopsoas actually will roll over the pubic brim, and can cause irritation and inflammation from that. Most of the time, physical therapy, sometimes some kind of manual therapies like Grafton or dry needling can also be attempted too. Age limits on knees. Depends on the knee condition. Certainly patients under the age of 45, if there's a meniscus tear, vast majority of the time we try and do a meniscus repair. There are certain types of meniscus tears though nowadays, like meniscal root tears, were really good regardless of the age. We are trying to repair them. So like a meniscus root tear, if the patient doesn't have a lot of high grade cartilage damage in the same portion of the joint where that meniscus tear is, we want to try and repair it because it will preserve that knee joint. Let's see. I think so. Jensen with IRG has been recording this. I will defer to him as to how you can get the recording, but yes. And then, can massages help the psoas? I absolutely. I have a lot of patients that have gotten some good relief with some deep tissue, sort of sports massage, whether it's through a physical therapy group or other. What's the relationship between hip preservation and hip replacement? So hip replacement is basically when hip replacement is when there is really, bone on bone, or there's high grade cartilage damage, joint space, or what we call joint space narrowing. So where the space between the two bones has become very thin. And what we do for that surgery, and that's when I say I actually don't do that. I do everything short of replacement, right? Once you've cut out the ball and the socket, we're not preserving it anymore. And that's what a hip replacement is. That's where we take out the ball and we put in a new ball that's attached to a stem that goes down part of the top portion of your femur. And then we put in a socket, sort of a mechanical socket, that now provides you a stable and non-painful joint. It is a very successful, excellent surgery for patients with advanced hip arthritis. And I would say, vast majority of patients, we try and do hip arthritis, a hip replacement for, after the age of 50. And again, like I said, there's exceptions to the rule that I see all the time just by the nature of my work. But the thinking is that a lot of components of hip replacement have improved where they're going to last, 20, 30 years. But it depends upon the patient's sort of activity profile too. Certainly I see I see 50-year-olds that are still trying to run marathons and, climb mountains, and a hip replacement they probably wouldn't tolerate. And if they have still enough joint space remaining, their tissue quality is still good enough, then we should try and do a hip preservation. So surgery. So there's a lot of, patients between the age of 45 to, 50, 55, oftentimes they end up in a bit of a gray area. And so my team and myself, we try and kind of help, figure out, navigate where a patient's best going to be served by, whether they see me or do we need to have them see one of our joint replacement colleagues. Anything else? Well, people are maybe thinking of any last minute questions. Jensen, I do want to thank you and IRG Physical Therapy and Shannon for this platform. This is, I really appreciate being able to educate and connect with community about something I'm really passionate about, and about something that people just don't have a lot of education and knowledge about. So I think this is really great and really important.